Okay, again, good afternoon, everyone. I'm going to give you all a little bit of an origin story that has brought me to you all today. It also has a lot to do with why the Free Market Medical Association was formed. But I want to start off and explain to you all does everybody know what a third-party administrator does? Okay, 1, 2. Okay, that's what I thought. I mean, as Sheridan was going through, everybody raising their hands, who everybody was. It's something that I find a lot when I talk nationally about. I have as in my audience many times physicians, and physicians know very little about the insurance or the benefits world and how employers fund their medical claims, et cetera. And so I'm going to spend a little bit of time talking about that real quick. So we are an independent third-party administrator. So my day job is running the Kempton Group Administrators. We are a family-owned, independent third-party administrator. Our board of directors, we had a meeting a little bit ago, eating lunch. It would be my wife and myself. That's it. We're not fueled by private equity. We have no outside investors. We truly are a mom and pop shop. I'm second generation. My father started the company in 1969, right out of college, went to work for the family business. Yep, you get the idea. My son and daughter, third generation, are now at the company, and we hope, we all know what the statistics are about second and third generation businesses, but we're hoping to beat the odds. So in 1992, when I came to work for the family business, that was a pivotal year. I don't know about Idaho, but in Oklahoma, 1992 was an interesting year. That was the year that managed care came to Oklahoma. And for some of us physicians maybe in the room, I don't know if you all remember, does that sound about right? I mean, that's when everybody started joining networks, right? You were in network, or am I going to join this network or that network or what network? Well, in 1992, when I started, there was no such thing as a network. The day I started, there was no such thing as a network. But the very first thing that I got to do was introduce this brand new concept to our employers. And that concept was the PPO network. And that was very interesting for a 22-year-old college kid going out and telling employers and their employees, well, as of January 1, you can go to these hospitals, but not these hospitals. And oh, by the way, you need to make sure that your doctor is in this book. It was not fun. Prior to that, when let me back up a little bit and tell you a little bit about what a TPA does, though, first, before we go too far in. So all of our clients are self-insured. That means that the monies that they would normally use for their insurance and send to a Blue Cross or an Aetna or United, those dollars they don't go anywhere. They stay right there at the employer. And the employer will hire a third party, an administration company like me, to receive the medical bills, the prescription bills from their employees and from their dependents. And those bills will come to my office, where we then will process those medical claims. And when those claims are ready to be paid, I write a check on the employer's bank account. So they are directly paying for their employees' medical benefits. Make sense? So a dollar saved is not a dollar that I get, and it doesn't go to an insurance company. A dollar saved is simply a dollar that stays at the employer to be able to use for payroll or anything else. A lot of my competitors in the TPA world, they do everything they can to kind of look like an insurance company, and they play a lot of the insurance company games. I don't know whether we're just cursed with a conscience or ethics, but we try very desperately not to do that. We work more like a law firm or an accounting firm. Our clients pay us a flat per employee per month fee to manage and run their health plan. and process their claims, answer the phone, all of those things. But as you can probably see, if we're writing checks on the employer's bank account, if my employers get taken advantage of and they go to a hospital that charges $40,000 for something that should cost $14,000, that doesn't help or hurt me, but it absolutely hurts that employer because those dollars were not spent wisely and their costs go up. And when costs go up for an employer, most employers react by making the benefit plan crappier, and nobody likes that. So back to 1992, now that we're kind of up to speed. Before managed care came around, when we would get a medical bill, the bill was paid up to a scheduled amount that was in the insurance plan. So in other words, if you broke your leg in the insurance policy, we're not in the insurance business, so we call that a plan document. But in the plan document back in the 90s, it would say, you could open this book and it would say, broken leg, $750. That meant when we got a bill for a broken leg, we already knew what we were gonna pay, $750. And if the patient went to a hospital that charged $1,000, well, there was $250 that was going to come out of their pocket. And that's the way medical insurance was done prior to about 1992, at least in Oklahoma. And because of that, there was an impetus from patients to ask their physicians, what is this going to cost? And the reason is because they had their little book that said what their plan was going to pay. And they knew if their doc or their hospital charged more than what the book said, then that was going to come out of pocket. They could do whatever they wanted to, but price was definitely part of the equation. When managed care came around, it was the most unmanaged thing ever. That's why I always use air quotes that's my code for it's BS. But when managed care came around, all of a sudden, you didn't worry about what it cost anymore. We were told from the networks to tell our employers they don't need to worry about what it costs anymore because we are going to negotiate on the employer's behalf. We're like, great. Well, how's that going to work? Well, whatever the hospital bills, we will negotiate a percentage off of that. And we thought that was a pretty cool deal because we assumed we already knew what the hospitals billed because we had already been doing it for a couple of decades. And we said, well, if we're going to get a discount off of an already reasonable price, then that's going to benefit our employers, and we think this is a pretty cool deal. That's not what happened. What happened is the PPO networks, they were able to have these discounts off of an already reasonable price because they would tell one hospital, we will prevent these employers from using your competitor because they won't be in network, but you will be. And in exchange for that, you're going to give us a 20% discount off of what you used to charge. And that was great. And it worked for us, it worked for the employers, and it worked for the medical community. But what happened was the hospitals started talking to the networks behind closed doors. I wasn't at the table, nor were my employers. And they started having this conversation. They said, we're not able to sell our network to as many employers as we would like to because they don't want to use you. They want to use your hospital and this hospital and that hospital. They wanted more choice. Well, I didn't go to economics, so I didn't get an economics degree, but I knew that the only leverage that these networks had was by if I'm a hospital and I can cut out my competitors by joining a network, then it's in my interest to give a discount. But when the network started saying, we need more choice for employers because they want more choice, the network should have said, well, the only way I'm able to give you a discount is by reducing your choice. But they didn't. They said, no problem, we'll get you more choice and we'll sign up your hospital and your hospital and your hospital. So their networks got bigger and bigger and larger and larger. And then the hospitals that were giving a reduction off of their already reasonable price, they said, wait a minute, why am I giving you a discount for patients I already have? And not only that, these patients can go anywhere they want to go. So I don't want to give you a discount anymore. The networks responded in the back room and said, don't worry about that. We'll let you raise your fees as long as you keep giving us a discount. So in other words, we'll let you raise your fees by 30% if you give us an additional 15% discount. That way, you make 15% more money. I'm a network, I can show the employer that they're saving more money, but at the end of the day, their actually costs are going up. The discount's going up, but the gross charge is going up. So networks just basically became a sham. And that's what we all know today, right? But that's how it really happened. Flash forward from 1992 to 2010, networks did become just a joke. And I saw my employer's costs going through the roof in that period of time. I wasn't having a real good time anymore. I was now CEO, my father had passed away, and I felt like every time I went to an employer and they said, Jay, why is our cost going up? I would have to tell them, well, that's just the way it is, but we're doing everything we can to maintain your costs. And I knew that that was a lie because these networks were the ones that were basically in cahoots with the large hospital systems and costs were rampant, out of control. By that time, about 2010, I was all funned out. I was about ready to sell the family business. I could go on for 3 hours telling you a lot of other things about the healthcare world and a lot of the games that are played in pharmacy and also with the networks. It just goes on and on and on. But suffice it to say, I concluded that I'm the one that saw the bills. I'm the one that saw these discounts being applied, and I saw right through them. They were a lie. What was the tipping point for me was, again, this was about 2010. I had just told my employers that, yep, your costs are going up by 10, 20%. And I had a meeting with our largest network partner at the time. The large network partner came into my office, started the conversation with, we've got good news. Our average discount is going from 46% off of billed charges to 52%. And I had just been rolling out 20% increases for my clients, and I just said, this is Barbara Streisand. Don't come in here and lie to me. I get it, you're lying. So anyway, I was ready to just get out of the business. About that time, I was introduced to an individual, Dr. Keith Smith from Surgery Center of Oklahoma. I was introduced to him by one of my clients that happened to be Dr. Smith's next door neighbor. That's very ironic, I think it was fate, I really do. But I went and made an appointment, met Dr. Smith at the Surgery Center of Oklahoma. I was highly skeptical of him because being a medical provider, he was obviously responsible for picking the pockets of my employers and was obviously in cahoots with the networks. That was what I thought. Little did I know, when I walked in the door, he looked at me exactly the same way because I'm a big bad insurance guy. And I come with all the baggage that goes along with that. And after about an hour meeting, I learned that, first off, that he didn't like networks any more than I did. In fact, he was trying to push back against them by bundling every medical procedure that they did at Surgery Center of Oklahoma, pre-negotiate with his surgeons, with anesthesia, with his facility, pathology, radiology, and come up with a all in, all done cash price, and he posted it on the website, on his own website, cash and carry. He told me that story. I thought that was a pretty cool story. And I looked at his website. Again, this Surgery Center of Oklahoma is 3 miles from our company. I drove by it every day. And all I looked at it was just a network provider. I didn't know they had an alternative pricing structure that was on his website, because what medical provider puts pricing on a website? I never even looked. So as I'm looking at this pricing and I'm getting really excited about it, he goes, not so fast. That's not for you. Your insurance. That's for cash customers. And I said, well, my employers are all self-funded. I was thinking, I had, as I said that, I felt like I had this big halo on my head because self-funding is so great. He said, yeah, self-funding, no, I don't like self-funding. I was like, what do you mean? How do you not like self-funding? There's no insurance company involved and all these things. He said, well, when self-insured employers walk through the door, they hand my front desk an Aetna card. And to us, I can't tell the difference between a fully insured Aetna patient and a self-funded Aetna patient. And the contract in which I'm beat up with is also the same contract. I had never heard that. I had never even thought of that. I said, okay, I can see where you're coming from, but my employers aren't with Aetna. My employers are with this little old family company here, and all they want to do is provide the best healthcare they can to their employees at the lowest possible price point. And if you need cash, we can figure that out too. As any good CEO, I didn't know how I was going to do that at the time. But that was for the car ride back to the office. But what we did is we ultimately did figure out that if the way we did it operationally is if you use Surgery Center of Oklahoma as one of our clients, we would waive through your benefit plan. We would basically just wrote in the plan, if you use Surgery Center of Oklahoma, the deductibles and co-insurance and co-pays, none of that applies. And we'll write Surgery Center of Oklahoma a check for their website price. So again, if you're following along here, I went from I'm ready to sell the business to, okay, well, this makes it a little easier to wake up in the morning because I found this freaky unicorn guy at Surgery Center of Oklahoma that was doing the right thing. And his pricing was an eighth to a tenth of what the discounted prices were at the big hospitals across town. Saved my clients a lot of money. But that's not why I'm here in front of you today. The reason I'm here in front of you today is after my clients had the opportunity to buy from Surgery Center of Oklahoma for free. The employer was paying the whole thing, but the patients had no out-of-pocket. It was what happened next that transformed my career and caused the FMMA to start. And it had nothing to do with Surgery Center. Well, it did have to do with Surgery Center of Oklahoma, but it wasn't because of them. We still are, but we're a relatively small operator in Oklahoma in the region. Back then we had maybe 8,000 employee lives that we managed. We're now about 30,000, so we've grown quite a bit. But we were a small organization, and when we started essentially incentivizing our patients to buy from a high-value medical provider with no out-of-pocket, Dr. Smith had a competitor right next door, a much larger full orthopedic hospital. Surgery Center of Oklahoma's got about 29 employees on staff. This one has 700, so much larger organization. That much larger organization was my biggest client at the time as well. We ran their health plan. I got a phone call from the CEO of McBride Orthopedic Hospital, right next door to Surgery Center of Oklahoma, about 3 months after we started buying from Dr. Smith. Again, if you're following the story, this is a client also, not just a provider, but a client. He was red hot. He wanted to know what is going on with the little pipsqueak, freaky tinfoil hat wearing doctor next door. Because he's had his third surgeon come to him and say that a case has been canceled a day before the surgery. And when they ask the patient, why are you canceling the surgery here? They're told that they're canceling it here because they're going next door to Surgery Center of Oklahoma. And when the surgeon says, why are you doing that? This hospital CEO says, they tell me because you, Jay, make it free if they go next door. What are you doing to me? Again, a client. I had to gulp pretty hard, and I just told him the truth. I said, well, he's got that website pricing, and it's really good, and it's cash, and we're just buying at that price. And as opposed to him firing me or threatening a lawsuit, he said, we can do that too. In fact, we're an inpatient orthopedic facility and they're a little ASC. We can do things they can't do. Give me 2 weeks and I'll have some bundled pricing for you. I was stunned. 2 weeks later, I had bundled pricing, but not for ACL repairs and not for bunionectomies, but for spinal procedures and full hips and much, much bigger things. And the pricing was better than the network pricing. It was very comparable to Surgery Center of Oklahoma. That was great. A few months later, and so we added McBride Orthopedic Hospital to our new little free market network. We didn't know what to call it back then. We didn't even have a name for it. And then about 3 months after that, I get a phone call from a physician-owned cardiac facility in Oklahoma City, Oklahoma Heart Hospital. They had heard what was going on in the orthopedic world, and they had piloted a Medicare bundled payment program that went nowhere, but they had a bunch of cash bundles sitting on the shelf. And they wanted to know if I was interested. Said, absolutely, I'm interested in buying from you at that price. And so they became part of our program. We now call that program the Kempton Premier Provider Program, or KPP Free. When you utilize one of these providers, it is paid at 100%. Dr. Smith also saw that many of my competitors that were in love with the networks, because they weren't cursed with the conscience like I was, they were now starting to come to him wanting to buy at his website pricing as well. So he and I got to start talking a little bit, and what we were seeing were he had competitors that were coming off the bench competing with him using his model, and I had competitors coming off the bench that were also buying from these medical providers on a cash bundled basis. We thought that was pretty darn cool, because what we both had wanted was starting to happen right before our eyes, and was not because the state of Oklahoma passed a transparency bill. It was not because the government had passed some legislation. It was not because Blue Cross decided to do something. It was because buyers and sellers were starting to make choices based on their own self-interest. And we said, my gosh, this is the kind of DIY healthcare reform that we've all been looking for. How do we take the story of what happened in Oklahoma City and share it all across the country and talk about simple, mutual exchange, again, free market principles yet applied to healthcare. And that's where we formed the Free Market Medical Association. Okay, I'm going to skip around a little bit. My story went pretty long. I want to show you a little bit about the discount illusion. I've got a couple of slides that'll go through really quickly. This pricing you see here for a hip replacement. That's real. That's from Oklahoma. Those are network prices. So those are not the build charge. Those are the amount after the network negotiation. And you can see just in Oklahoma, a network is able to negotiate a price down to $27,008, all in, all done for a hip. But they also allow other facilities to charge $84,000 after the discount. That's a 3,100% variance. If I'm paid to negotiate and I can't negotiate any better than a $3,100% difference between the low bidder and the high bidder, I should be fired, but it happens every day. Again, the other illustration there is the difference on a flat panel TV. If you were buying from Walmart if you had a price of $579 from Walmart or $427, that's 135% variance. My guess is for that model of TV, Walmart had a hard time selling very many of them because that's enough of a difference to make people walk and choose differently. Yet, over here in the 3,100, guess who charges the $84,000? It's the highest volume, largest systems in Oklahoma. And it does not cause people to choose better. That's what healthcare being broken looks like. Okay, this is more along, do we have any employers in the room? One. Maybe we talk after. This next couple of slides are really about strategy. How does your self-funded plan get out of, and I think Matt Ort's going to actually be talking a little bit about that when he's up, so I'm not going to spend much time on there, but there is an entire strategy of how do you get from the status quo to having a free market-based health plan. And it is not a one-size-fits-all. It's kind of like what Rod had said, if you see one DPC, you've seen one DPC. Well, if you've seen one free market healthcare strategy, you've seen one free market healthcare strategy. They do definitely vary. This is all some examples of what we see in the country. This is our data from Oklahoma, but you can see coronary artery bypass surgery. You can see the average billed amount. Then the average network allowable in the state of Oklahoma is the blue line, and then what we're able to buy it for on a cash basis. This is a coronary bypass. That's not just the facility charge. That is the all-in, all-done number. So that's going to include everything. Same with the knee replacement, same with the colonoscopy, steroid injection, MRI, and CT. You see where cash truly is king. Why in the world would insurance companies not want to buy with cash? It's because they don't want costs to go down. Most insurance companies will make, not only do they make money off of the premium, but if you have an insurance company that is administering a self-insured benefit plan, because a lot of them do that as well, they will charge the employer a percentage of the discount. It's a huge revenue stream for insurance companies. But you can see it's Barbra Streisand. But the hospitals love it. So does the insurance companies. It's a symbiotic relationship. All right, so I'm over, but you put me over, so I'm gonna go a little over. Until you give me the hook. All right, this is an example, FMMA bundled cash prices providers in 2011. As far as I know, Surgery Center of Oklahoma was the only game in the country that was offering all in, all done bundled prices that were available on a cash and carry basis. Flash forward to 2025, and you see in Oklahoma City, we have 304 medical providers that are offering procedures on a bundled cash basis. This movement has taken off, and I have to give credit where credit is due. This would not happen if it wasn't for it could have been anybody, but it happened to be Surgery Center of Oklahoma in Oklahoma City that threw down that gauntlet And a lot of medical providers came into this space out of self-preservation. In other words, if I don't compete, I'm going to lose that case, and if I don't compete in this way, I'm going to lose this employer group. This is what we do at the Kempton Group. Just show you navigation of patients to high-value medical providers has become a big part of what we do. We still use networks. We advise employers what they're giving up, but in some markets, the network is all that's available. But every chance we get, we try to navigate our clients and their patients to high-value providers. You can see back in 2012, we did 146 in the year of 2012. In 2024, we did 31,798 bundled surgical cases. We're doing a little over 2,500 every month now, and that's where a patient is being told that they need to have this procedure done at a hospital, and we instead say, you can actually have that for free if you choose a higher value medical provider, and it's not just go here, it's free. It's free because this is what the free market provider charges, all in, all done, and based on our data, this is what the hospital that you were going to go would charge, all in, all done. And because the price is so much lower, your employer is going to share that savings with you at the point of sale by waiving your deductible and your coinsurance. You can also see the estimated savings there. We have a very good database of the network allowables for if you had this done at XYZ hospital or at XYZ facility, what the amount after the discount would be, and you can see the delta there. And in 2024, we estimate that we've saved our clients about $41 million. We could talk more about bundling, but we're going to skip to the last slide here, which is the strategy. If we're talking about employers, the key is the employer must be self-funded. If the employer is not self-insured, then they're not a buyer of healthcare. If they're fully insured, they're a buyer of insurance, and their insurance provider is who's buying the healthcare. So the key is you've got to be self-funded. Next, we've already talked a little bit about deleveraging the network's influence. Next one, direct contracting with providers. That would be direct contracting with places like Veritas Surgery. It would be direct contracting with places like Dr. Story's DPC clinic. Choose vendors whose priorities align. There are so many cost containment vendors and pharmacy benefit managers and third-party administrators out there that get paid when healthcare costs are high and stay high. If you're doing business with one of those kind of an entity and the results aren't good, the results are good, just not good for you. They're good for the vendor. And then educate and incentivize members to make good choices. Our company, we've moved way, way away from saying, go here and you can get your surgery for free. We spend an inordinate amount of time educating patients. I'm talking about linemen at electrical companies. I'm talking about blue collar, white collar, professional. Americans are really good buyers of goods and services. In fact, we're probably the best civilization on the planet Earth at discerning value. We've just been told for at least 2 generations that we have no standing to discuss or discern value when it comes to healthcare, and that's a lie. And every one of us can be a better shopper for healthcare, but it's incumbent upon the seller to making their product easier to understand, so they can make better choices. Direct primary care is a huge example of that. I'll be here on a panel as well to talk more about and take individual questions, but thank y'all.